Okay. Well, thank you for coming to my presentation. I'm Jackie Rawls, and I'm the director of the Future Nurse Anesthesia Program here at Marion. And part of my requirement for a Doctor of Nursing Practice degree, obviously, was a research project. I'm a pain specialist since 2002, so I chose to do a project on sacroiliac joint pain because it was my pet peeve. I felt like it was the most misdiagnosed condition that I saw in 10 years of working in a very busy pain clinic. So this is entitled The Use of Clinical Tests in Diagnosis of Sacroiliac Joint Pain, Provider Preference versus Optimal Practice. Just a quick overview. The incidence of sacroiliac joint pain as a cause of low back pain is up to 30% in the public. Their referral patterns from the pain make it difficult to diagnose. People often confuse it with spine-generated pain or hip-generated pain. When you review the literature, there's actually over 20 physical assessment exams, maneuvers, or provocative maneuvers that are aimed at diagnosing sacroiliac joint pain, which is crazy, right? No single test or provocative maneuver results in a reliable diagnosis, so people need to be doing, obviously, more than one clinical exam. These tests are often subjective because, and objective as you're looking at the patient, different people apply the test differently when you're doing hands-on. Some people generate more force on the joint to try to reproduce pain. So there is some reliability, inter-rater reliability problems. And then a combination of tests has been shown to increase the diagnostic accuracy. We know that diagnostic errors cause problems. They have delayed care, increased cost of care, potential harm because we are doing incorrect care with an incorrect diagnosis. It's estimated then to impact 12 million people a year in the United States alone. So my problem statement was that there's no diagnostic imaging study, there's no lab analysis, no biopsy that is going to confirm sacroiliac joint pain. So we need to look at assessment. Assessment and patient history is a very important determinant of our diagnosis and differential diagnosis as we're assessing this joint. So there's numerous tests, as I said, to stress the joint, to try to reproduce pain or confirm pain or even rule out pain. And I was trying to find out, what are people doing? What are they using? Because, again, in clinical practice, I saw problems with accurate diagnosis. There's also some controversy about which tests have the best diagnostic accuracy or value. So the purpose of my study really was to determine which clinical tests are being used. So I'm trying to establish what's the current state of practice, determine if the tests that are being used are really the ones that should be used according to literature results, and identify then provider group preferences for the use of the examination test because it's a multidisciplinary study, and then assess for any knowledge gaps that comes out of the data as far as using the tests. Well, when you're looking at diagnosis, we need to come up with what's the most accepted diagnosis out there. So the International Association for the Study of Pain had determined SIJ pain diagnosis to be pain in the region of the joint, and for the non-clinical people in the room, it's a big joint back here. Okay, it helps with connect the spine and the pelvis. It causes low back pain, normally below the level of which the spine ends, but it can refer up, it can refer around to the groin, and that's why it gets mixed up with hip pain. So that, a lot of times patients will come in and say, my pain is right here, which is one of those diagnostics, believe it or not, called a Fortin finger sign. And then pain reproduced by specific provocative tests that we're doing to stress the joint, and then that pain should be completely relieved by diagnostic injection, which I always use 2% lidocaine, works quick, fast, you know in 15 minutes or not. If all of those things are met, you can say, yes, this patient has sacroiliac joint pain. So a summary of the literature results, again, over 20 tests are being used for diagnosis. The evidence was very strong for a multi-test regimen in the assessment, and that we should be using 5 tests. If 3 are positive, there's a very high degree of sensitivity and specificity for the pain. Several studies then suggest inclusion of certain tests. So the thigh thrust is the highest sensitivity. The distraction test is the highest specificity. The compression test has the highest positive likelihood ratio for the diagnosis. Makes sense. Everybody should be using those tests, right? Wouldn't you think? Well, guess what? Doesn't happen. There was no further specification of which 5. So if we're going to use 5 and we know 3 are kind of been considered optimal or ideal, what are the other 2? There's nothing in the literature that says what the other 2 should be. There is one that's kind of recommended as the 4th one, or any order and an algorithm of how they should be performed. The IOM did a report in 2015, published a report on improving diagnosis in healthcare, which I think is really pertinent to this study. We know that diagnostic errors, there's a lot of them out there, and it's causing our patients harm. And we're not being the best clinicians we can be, obviously, if we are making these errors. But we know part of the problem that came out of this report is that we as clinicians get limited feedback as to what we're doing to cause the error, or what we should be doing to reduce the error. 5% of U.S. adults seeking outpatient care each year suffer a diagnostic error. And earlier, as I said, the problem is it prevents or delays appropriate care. It provides unnecessary or even harmful treatment to patients, results in psychological issues for these patients because of continued pain, financial repercussions because their costs are so high if they keep coming back and their pain's not relieved. And it's the leading type of paid malpractice claims. Further, this report said we shouldn't focus only on error reduction, but on ways to improve diagnosis. So I had to mention, being in the nursing department, conceptual and theoretical framework, which most of us hate in research sometimes because it's hard to find something that fits very well. Most diagnostic theories, they do look at overdiagnosis, underdiagnosis, misdiagnosis, incorrect diagnosis, which is certainly a part of what I'm looking at. But at the core concepts of all diagnostic models are these diagnostic process failures. So incorrect workups, which speaks more to what I'm looking at. And then the label failures. So we did diagnose it incorrectly, but to me, it's a result of incorrect workups. I found a theory in 2013 by a guy named Newman Coker that absolutely fit this project. He added 2 new categories. He talked about suboptimal diagnostic processes and optimal diagnostic processes. Suboptimal was very interesting to me because these are processes that are considered standard. They're accepted practices, common practices in clinical settings, despite these practices not being of the best scientific evidence, which makes them really what we would consider a reducible error, right? But they're not substandard care because they're commonly accepted and used. They're not considered preventable errors by our normal quality assurance or safety programs because of the fact that they're commonly used, everyday accepted practices. Kind of interesting. So optimal diagnostic processes then need to be inclusive of current scientific evidence and representative of best care or best practice. A gap in best practice or use of lack of use of enhanced technology can lead to erroneous diagnosis. So this contemporary model, which was published in 2013, really to me promotes an understanding of what suboptimal care does, the impact on reduced quality of care, and presents a very compelling argument that we need to make sure we understand new advancements, new technology, best evidence, and we disseminate that, and we implement that if we're going to improve diagnostic errors. My study was done through a survey, and we'll talk about that a little more, but it's really a descriptive statistics study. Cross-sectional study with a goal of describing the current state of practice and then comparing that. Done through a survey that then documented information about the tests used. The results were then analyzed to see if the professional characteristics of healthcare workers, their different disciplines, influence the choice of their tests, or if their years of experience in pain practice influence what tests that they chose. And then the results were analyzed further with the help of a statistician to see if these people are using the 3 optimal tests in the literature. Yeah, believe me, I couldn't write that program. So I did an electronic survey via SurveyMonkey because at Barry they wouldn't let me use Qualtrics because they didn't know what it was, and I would have to go down and appear before the IRB. So I ended up using SurveyMonkey, which is what they wanted me to, so that I could find out what providers know, what tests are they most familiar with, what are they using, what's their preference in diagnosis. I purchased a mailing list from the American Academy of Pain Management thinking, okay, these people should be really up on pain, right, as clinicians. And that list included pain practitioners whose scope of practice would include or could include SIJ clinical examination. And that's physicians, MDs, DOs, nurse anesthetists, nurse practitioners, physician assistants, physical therapists, occupational therapists, which yielded me just over 2,400 emails. My survey was very simple. I just wanted simple questions so I could say this is a baseline. Where are we with what's going on? I wanted it to be quick, 5 to 7 minutes to complete, so it would hopefully increase participation. And you can look at SurveyMonkey and see how long it took people to do your survey, and it took about 3 minutes on average. There were 3 single answer multiple choice questions. The number of tests people are using. Remember I said 3, they're suggesting 5, but 3 of 5 positive. So how many tests are you using? Then what's your discipline? What's your years in pain practice? There were 2 multiple choice, multiple answer tests. So there was a checklist of 10 tests. Which tests are you familiar with? Then the second one, what tests do you commonly use in practice? The last question was a rank order. So ranking your preference of test use from 1 to 10. So I could see what tests are being used. The cover letter included, of course, IRB approval with ability to email me, which I had a couple of emails of people that had questions, and then the ability to contact the IRB rep at Berry or to opt out via an electronic link. I convened a panel of 8 experts, pain practitioners, because with surveys, it's all about reliability and validity, right? Are we asking the right questions? Are they going to understand the question the same? Are we going to get the information back that we want to get back? So I went across all disciplines and pulled some friends and had them look at the survey for format, readability, and then had them actually review the questions for face validity, take the draft survey to give me feedback. And even despite all of this, we all know that results can be affected by user misunderstanding, question or answer misinterpretation, or just human error in recording your answer. So out of those 2,413 emails, I sent them out. There was a 2-week response time. I sent a reminder email after 1 week. 498 were undeliverable, which doesn't say a lot about the database, right? 1,248 just went unopened. 142 people opted out. I had 525 potential participants. 114 actually opened the survey, some ignored. 9 were disqualified from the first skip question because they did not use clinical assessment tests in diagnosis of SIJ pain. And then 25 submitted an incomplete survey. So I had to eliminate them, leaving me 80 full responses. And this is by discipline. So overwhelmingly, more MDs than anything else. DOs, CRNAs, wait, this is wrong. DOs, here, CRNAs, then nurse practitioners, PAs, PTs. So not great numbers to do complete interdisciplinary comparison statistically. So each response that came was analyzed. We divided, after I consulted with the statistician, into 4 groups so that we did an overall comparison and then an intergroup. So we put the physicians together, trying to look at similarities in training. We put the nurse practitioners and the NPs as advanced practice nurses together. Had to leave the PA and the PT separately because the training's too different. And then no OTs responded, but there are only 14 on the roster. It just depends on where you work. The OT in my pain practice did a lot with SI joints. Some don't. So then each thing was analyzed, each question, and then I looked for the association between practitioner groups and outcomes. Even though it's not a scientific study, in my defense, we had to say, okay, what would be the independent variable? Well, that would be the practitioners because we're causing the effect. And then the dependent variable would be the number of tests, the knowledge of the tests, all the tests basically in the answers. So those are nominal variables, except for ranked order, which is ordinal. The associated variables were the discipline and the years of practice. So if you look at study design, we know that we have to do a non-parametric testing. And again, the study's trying to answer what's current practice, what's reflective of best practice, is current practice reflective of best practice, and are these actually 4 groups different in discipline or years of experience. So when we looked at how we were going to test these, the rank preference question ended up being a simple frequency distribution. When you have 80 people ranking 10 tests, that's a lot of data. The other questions went to a chi-square for independence. So we could see, are these variables independent of each other? So again, I looked at the number of tests commonly used in assessment, specific tests that they were familiar with, specific tests they're utilizing, rank of test preference, and then this is where the statistician was a big jewel. She pulled how many actually were using the ideal 3 tests. So here's a graph with a lot of stuff on it. But basically, the number 1 preferred test is a Faber-Patrick test, which is not highly specific to SIJ. Interesting, right? The number 2 ranked was compression, which is the highest positive likelihood ratio. And even if we look at the top 3, we only have 1 of the ideal in it. We have to go to 4 to get the one that has the highest specificity, and our highest sensitivity, our true positives, ranked 7. That's a cause of concern. When we looked at all participants, only 80% used 1 of the ideal 3 tests, 32% used 2, 7.5% used 3. Big education problem. No difference in discipline. So the results indicate we have an education gap. We also generate a lot of questions for the future. Correct diagnosis, we know, is a national focus right now at the core of quality care indicators, patient safety initiatives. The goal of practitioners, and we need to get on it because we can be harming our patients. The goals of the project were to try to increase appropriate diagnosis, increase practitioner knowledge base and competency, and really improve our level of expertise. Deliverables, which are important for DMP projects, educational tools, PowerPoints. We can do a module for people. I've done a poster presentation. I've been asked to speak at the Academy Pain Management meeting. I've submitted to a peer-reviewed journal. I'm waiting, and I've been asked to write an article for the American Academy of Pain Management, but it's a non-peer-reviewed journal, so I'm just waiting. These are references, and that's one of my patients having an SI joint injection. So the needle goes in the joint, you put contrast, and you can see it spread. Okay, I think I'm right at 20 minutes. Am I? Okay, questions? Anyone? Yes.
What I really love hearing about is that, this idea of scientific best practices, I think that's a common problem with recommended disciplines. That's certainly a common problem in higher ed in general. We have a lot of knowledge about best practices, but getting out to people who are actually on the ground doing it, I think that's really easy to think.
Oh, yes, thank you. Yes.
How surprised were you at these?
Oh, I was surprised because I've been a member of that Pain Academy for 8 years and been on the board of directors and been to their meeting, and they have great clinical meetings. I really thought I would see more difference in the years of experience and say, okay, people that have been in for 20 years are using older. No, very surprised. And actually, in speaking with the Academy's educational director, she was very surprised too. Yes. That is the case. There are 2 of them are very quick. One takes a little more time. And the one that was the highest preference that really isn't very specific or sensitive is so easy to do. And I think clinical time is one of the questions in my manuscript I raise. Is this affected by the time that clinicians have with patients? So there needs to be more information that we gain in order to adequately address it. But I do think time is a big factor. The training would be interesting to find out too, like what are you actually taught in your training program? And if you have specialty pain training, because we have fellowships, physicians have fellowships, nurse anesthesia has a fellowship. What are you being taught? I don't think so. None of these tests are really that risky. But you do have to be able, a couple of them, to get them on a table, an exam table to do. So that makes it difficult for some patients. All right, well, thank you very much.